embryology training in Mumbai. Ma'am has presented a lot of papers in both national and international forums. I recently also, ma'am, gave a few, very good talks at the just concluded ISAR in 2020 as well. With this small introduction, over to you, ma'am. Welcome, ma'am.
Hello, everyone. A very good evening to all of you. Thank you, Kiran, for the kind intro. And I think I would be starting my talk on advanced age fertility options, new horizons. This is a very good topic selected because it's one of the most challenging scenarios we face in our day-to-day fertility practice. And this category of women are increasing day by day. Thanks to women empowerment, gender equality, female child education, and career options, that the age of reproduction has shifted to a little less than a decade over the last 2 decades. And this puts us in a very challenging scenario of handling this women and trying to give them a baby. So starting my talk with the most important slide. This is which says that age is still the most important determinant factor influencing success after any fertility treatment. So this is a beautiful depiction by the ASRM, which says that there is a steady decline in the fertility over the years, as we all know. But after the age of 35, there is a rapid decline in the chance to conceive, especially when you want to conceive naturally. And this is the most important decade of a woman's life, which we need to help them out with. So why is there a shift? That is definitely because of the career options. Women don't want to start the family very soon. And this is very well depicted in our own study in Pune in 2016 in the IT group, which shows that 51% of the women visiting the clinic, gynecological OPD, do visit for fertility treatment, which is very higher compared to the other age groups. And this is also observed in other countries where they have noted of, say, more than 5 to 7 years in the age where women want to plan the pregnancy. Now, between 1970 and 2002, the percentage of first birth in women more than 30 years has increased 6-fold. In 2006, the fertility rate of women aged 30 to 34 was the highest of any age group, surpassing that of the previous highest group between 25 to 29 years. The first-time mothers who are more than 30 years of age increased steadily from 11% in 1987 to almost 2-3-fold, that is 26% in 2005. And the most important here is that in spite of whatever treatment we offer, the proportion of women who remain childless is 64% at the age more than 40 years. So now we all know about the reserves. We know that is one of the part of our obstetric career. We know, we are taught this, that we have oocytes from birth and it's a continual decline. Suddenly starts to fall from the age of, say, 30-35. And this is actually the age where women want to conceive. So this is the age we need to be in the fertility arena. Now, if you see this population, this is a population again which says that at the age of 35 the decline starts, which is aggravated again at the age of 38. So that is why 35 is kept as a cutoff for advanced maternal age definition. So when we talk to the age of 35 or say majorly because dramatic increase from the rate of baseline 30% at a younger age to 90% in the late 40s prior to menopause. This gradual depletion of ovarian reserves and on the other hand to progressive decrease in oocyte or embryo competence. So this is very important to understand that what do we mean by competence is that a grade 1 or a grade A embryo at an age of 40 is definitely different from the same embryo given at an age of 25 or a donor oocyte. So this is what is called as embryo competence, and it is different from embryology grading. This is again because of a lot of intrinsic mechanisms or factors in the oocyte embryo, which starts from impaired mitochondrial metabolic activity to a lot of epigenetic changes, and all these processes are directly or indirectly involved in proper chromosome segregation and hence modulating the competence of an embryo. So with this, the chance of producing a blastocyst might be even lower than 5% in women older than 43 years. Now, this is about the maternal age. Now, what about the paternal? Yes, there is definitely effect of paternal age. There is always a significant. We as consultants we don't look beyond this, but there has been an age-related decline in sperm function and male fertility. Not very clearly defined in men like menopause in women, but there is definitely a decline in testicular function. Semen parameters like volume, motility, morphology decrease with age, although a decline in sperm concentration has not been shown. There are a lot of recent studies, and I think my last talk which I spoke was increase in the DFI with paternal age, and there are a lot of meta-analysis to support this increase which is affected by age. Paternal age more than 40 does appear to be associated with risk of spontaneous abortion, even when the maternal age studies which such that either alone or in combination with the maternal effect. So it is associated with Alport's, achondroplasia, and fibromatosis. It's very important for us to understand the couple's age and what do we aim. We a woman or a couple with an advanced, say, maternal age. So what fertility treatment for those people is aimed at increasing controlled ovarian hyperstimulation with OIs or gonadotropins or IVF to improve the chances of pregnancy. Whatever treatment is done, intended to increase the number of months to balance decreasing oocyte quality. At age, we always talk about a chronological age, but there's something else. There is something called as a biological age. So definitely chronological age is most important predictor of ovarian response to FSH, but the rate of reproductive aging and the ovarian sensitivity to gonadotropins varies environmental, genetic, and now I would say lifestyle.
Ma'am, your voice is not coming.
Is more important than my voice is not coming.
It is breaking in between, ma'am. It's fine now, ma'am. It's fine now.
I think I'll give you a hotspot otherwise. Is it okay?
Yes, ma'am. Yes, ma'am. Please carry on. Yes, ma'am. Yes, ma'am. It's fine, ma'am.
Yeah, so biological age is more important than chronological age because first we need to understand at what level of the fertility declining slope the woman stands in. Now, with this, in 2016 came the Poseidon group, that is to understand where a woman stands with her ovarian reserve. This talks more about biological age. So if you see the group was done with 4 groups, that is the first 2 were with adequate or a borderline ovarian reserve. This Poseidon group is basically directed to diminished ovarian reserves, but in that, with an adequate ovarian reserve is the first 2 group. Here, one is less than 35, the other is more than 35. The poor ovarian reserve is again Poseidon group 3 or the Poseidon group 4, again divided into less than 35 or more than 35. Now, if you understand, this is advanced maternal age, but this biologically age is better than this chronological age. So this is where we understand that where do we categorize our patient? So our patient does she come in the Poseidon group 2 or Poseidon group 4 is very important for us to understand. So how do we understand whether this woman is in this group or the positive in group 4 is by one of the basic hormonal evaluations. FSH is definitely one which is more sensitive, specific in telling us the ovarian response to stimulation, though the sensitivity is very varied. AFC is the most predictable, best suited prognostic marker, wherein the AFC of less than 3 to 4 has a sensitivity of 9 to 73%, but specificity is very good to the tune of 73 to 100% in predicting poor response to ovarian stimulation. Early phase estradiol alone has limited utility, but E2 along with the FSH, that is the basal FSH, can tell us or help us prognosticate the woman's response to the ovarian stimulation. So if a woman has a high FSH, a low FSH with a high E2, that shows that this E2 is giving a negative feedback and hence the FSH is low. But in fact, the ovarian reserves are less. But when the E2 is high along with a high FSH, that means she has slipped down the fertility slope and the response is very poor. AMH definitely is one of the most promising biomarkers these days, but it has to be done by the right technique, either by the Gen 2 ELISA or by the ECLIX, which is the new one. In evaluation of male fertility, sperm DFI plays a very important role in evaluation of the male fertility, or especially in oligospermia, or when we know that the age of the male partner is high. Evaluation of tubal and uterine anatomy as a routine. This chart, it's a very interesting chart where we can understand that at the same age, the baseline FSH can be different. So we can talk about biological and chronological age, we understand from this chart. And if you see, the baseline FSH between 6 to 9 is better in advanced maternal age to give us a better prognostic factor. But whatever said and done, after a certain chronological age, the fall in the FSH is, the increase in the FSH is quite evident. But the same happens at a younger age, gives us a more bad prognostic factor. So coming to now, when we know that she is a AMA, we categorize her in a Poseidon 3, a 2 or a Poseidon 4. We know that we can offer IUIs to the Poseidon 2 category. But what is the evidence about IUI in advanced maternal age? So there are a lot of studies which are basically observational studies, which say that Scotch et al. Says that the pregnancy rates are definitely under 25, and we all know about it. Some people say it's better under 30. So to categorize that, 30 can be kept as a cutoff to continue giving 4 to 6 cycles of IUI. The pregnancy rates of patients aged 40 remain stable even after more than 3 cycles up to 6 cycles. That means that after 3 cycles, there's a plateau seen. This has been shown and evident in many of the studies. So for the first 3 insemination cycles, the success rate of women aged more than 40 and 41 did not differ from those women under 40. Now, these were all the category which were little diminished ovarian reserve and not very poor ovarian reserve. And no more than 3 insemination cycles should be attempted in these women. The overall pregnancy rates after insemination are 5 to 15% and thus clearly lower than those obtained with more invasive methods such as IVF or ICSI. This is again from the German IVF registry. So what we conclude from this is we would not go more than 2 to 3 cycles of IUI in Poseidon group 2. IUI, when we talk about IVF, we have to understand that first, there's currently no ART treatment strategy that can fully compensate for natural decline in fertility with increasing age. Adjuvant therapies may be of use, but the consensus has no clear data. Increasing the dose of FSH during ART will not improve pregnancy rates among women with an expected poor response. That is AFC between less than 5 would not improve with increasing the dose of FSH. Now, this is a very good study by Barash et al. It's a retrospective study which said that if you can see the chart and you concentrate on this age group and this age group, you don't find any difference in the number of euploid embryos when you increase the dose from 3,000 to 5,000. So if you're going by, say, 225 to 300 international units of gonadotropins per day, whether it is a monotherapy or a combination, if you cross more than that, you may not have very good euploidy rate, especially in this age group. The rate has been decreased with increasing FSH dose, which says that there could be detrimental effect of increasing the gonadotropin dose in advanced maternal age or poor ovarian reserves or hyporesponders. Now, therapy which exists to restore this intrinsic gamete or embryo competence. And hence what we can do is we can tailor a proper individualized strategy to aim at maximum ovarian response, get the highest possible number of mature oocytes which are more competent and give us a good embryo, a competent embryo. Now, what do we look at when we go into ART? So as I discussed about the gonadotropins, definitely the right selection and the right dose. Now, the selection dose is, we already discussed that high doses would not definitely help. Now, the selection, that is either you go with a monotherapy or you go with a combination, is very important, because there are a lot of studies and a lot of data these days which talks about LH supplementation, either recombinant or in the form of an HMG. So I would be discussing about this in the next 2 slides. The other hormones which have been shown a good effect is growth hormone. The effect of growth hormone is mediated by insulin-like growth factor 1, which works synergistically with FSH on the granulosa and theca cells. Low concentrations of growth hormone in follicular fluid are associated with fertilization failure, cleavage failure, and poor embryo morphology. And hence, we need to have a very good individualized approach for all these women who come for ART. Now, when we talk about LH, we know that the basics is 2-cell and 2-gonadotropin theory. So it is known that both of the hormones compensate for each other. But LH does have an effect on the granulosa cell because it prevents and protects the cumulus cells from apoptosis. This has an effect. This is the only hormone which has a paracrine signaling which supports the developing oocyte until ovulation, to ensure that this oocyte can sustain fertilization and early phases of embryogenesis. Now, this all has to happen in the early follicular phase of the cycle, wherein the follicles grow and the oocyte maturation starts. So hence, the supplementation of LH has to begin in the early follicular phase in hand with the FSH. And those women with a hyper-response to exogenous gonadotropins, when done with a monotherapy, will definitely benefit from LH supplementation. This is one of a very good systematic review and meta-analysis done by Confronti, published last year. And recombinant LH has been proposed again for hyper-responders in the same age group, say 36 to 39 or 38 to 39. And this has been again a systematic review published in Fertility Sterility 2018. So how do we understand? Now, I was talking about hyper-response to exogenous gonadotropins. Now, these women are the ones who have undergone a cycle of ART outside, and they come back to you for the second cycle of ART. So in this, there is a very good practical indicator proposed by Carlo Avighi. And this is nothing but an FOI, that is a follicle to oocyte index, which tells us about the percentage of oocyte number you retrieve with the antral follicular count. So now, if you see, the normal FOI is usually what we get is, say, around 70 to 80% or 90% is what actually the good FOD, that is a follicle output rate, would be in a good stimulated cycle. But our concentration comes on when it is a low FOI, and it is very common with advanced maternal age. So when you have a woman at an advanced maternal age, she could be this category, that is possident 2, wherein it looks pretty adequate, but when you go ahead, you can get a lower number, or she could be this category or this category, where you see a lower number and you get adequate number, or you see a lower number of AFC and you get less number. So this is one where you are getting a low FOI. So these are the category of people you need to concentrate. You have to customize or tailor or give an individualized approach of stimulation to these women. So how do you do that is you first make a protocol for yourself. So usually conventional ART with agonist is not being used for low responders, but now when there has been seeing cases of say low blastulation or embryological failures, people do try conventional ART after 1 or 2 cycles of antagonist failures. The most common ones used for AMA or diminished ovarian reserves is short or ultra short antagonist protocol. A minimum flare with a low dose of agonist will definitely help. Minimum stimulation is wherein you go ahead with a stimulation with oral ovulogens or a little gonadotropins, and you aim at a very few follicles so as to not to disturb the ovarian pool. But the limitations of minimum stimulation is that you need to do multiple cycles. So your main aim of decreasing the time to pregnancy doesn't get targeted. And secondly, every time the woman has to undergo stimulation or pickup, so it becomes a very tedious process for the woman, and it increases on the cost effectiveness, and that is the reason the number of oocytes come down. So overall, it becomes a little delayed protocol for advanced maternal age, and hence it is not very much advisable to go with the minimum stimulation. So the most best one is, if possible, to go with a short or an ultra short or a minimal flare antagonist protocol, or go for a pooling, go for oocyte on embryo pooling, and then do a frozen embryo transfer after 2 to 3 cycles of pooled embryos. The other concept, which is in double stimulation, which has been a lot of data published by Filippo Baldi from Italy, which believes in propitious moment theory. That is, multiple waves in one menstrual cycle can be utilized to retrieve as many eggs possible in the same cycle. Now, this is actually good for women who have less time or who are undergoing a fertility preservation for cancer, because the concept of having 2 pickups in one cycle may not be very acceptable for all the women. But the studies have said, in fact, yesterday there was a lot of discussion on double stimulation, that is diostim, which says that the follicular phase stimulation and luteal phase stimulation have yielded the same cumulative pregnancy rates and the live birth rates, and there has been no difference in the blastocyst formation. So this is again one of the options if the patient is not ready to wait. So once you have an embryo formed, you have your aim till the embryo, making a good embryo, and then you have to, next step is to select an embryo. So there's a role of PGTA in AMA, and what is it? So the role of PGTA in AMA is because in advanced maternal age, the risk of maternal morbidity and mortality increases in the later reproductive age. And strategy to comply with this premises requires to avoid transfer of aneuploidy embryos, increasing the pregnancy rate per transfer, especially when performing a single embryo transfer. That is, especially when performing a single embryo transfer. The role is less burden and complications because in advanced maternal age, as such, you have a independent effect of age on miscarriage, and multiple gestation would be difficult to handle in an elderly primate, as well as the short time invested to achieve a pregnancy. Aneuploidy testing cannot confer reproductive competence as only a tool to estimate such competence. Now, the limitations of PGTA is that the mosaicism, as we all know. So whether we do embryo PGT and then we know it's in mosaic, the chance of an autocorrection of an embryo which happens during the implantation process is missed. And this embryo, which would have been autocorrected to a normal embryo, would have been labeled as an aneuploid and discarded. You have a limited number of embryos, so do we take a chance of having an aneuploid, normal embryo labeled as an aneuploid or a mosaic, is one of the limitations of PGTA. The second thing is about PGTA is that if you see the age group of say 40 and above, the chances of euploidy rate is definitely less than 30%. So in this, when you have this chance of having aneuploidy, are we going to give her so less chance of having an euploid embryo, and at the end of the entire protocols having a diostim, double stim, pooling, you end up having no blastocyst to transfer, is the second limitation of PGTA. When you look at a single embryo transfer, the miscarriage rate could be more, definitely more, when the embryo is aneuploid. So PGTA helps us to rule out aneuploidy in such embryo transfers where you do single embryo transfer. But in a country like ours, where we look at 2 to 3 embryo transfer are justified all is a big question to be answered. So there's a lot of controversies and consensus to be built upon on PGTA practice in India. So why? Second reason why is because PGTA is in skill, and any damage to a single embryo is not tolerated in poor ovarian reserves or advanced maternal age. Now, this is one of the most important discussions today is current and future perspectives in reproductive medicine and technology. And this is not going to be very far away because we know how we are blessed to have NIPT in obstetrics and maternal screening. So this is a similar concept in invasive testing, non-invasive testing of embryos. So this is epigenomics, genomics, transcriptomics, proteomics, metabolomics. So this basically minimizes the risk of AMA through non-invasive approaches for embryo selection. So this, how is this done? It is similar to the NIPT, wherein the leftover products of IVF, which has been spent in the culture media, especially the one-step culture, in which the blastocyst is cultured. This has the molecular analysis, which is studied for screening of genomic DNA, and this labels it as a non-invasive PGT, and it is one of the definitely challenging and potentially groundbreaking perspectives, promising a lower clinical workload with a high cost effectiveness, especially in a country like India. So this is what we're looking forward in maybe in a couple of years to be used on a day-to-day practice. Now, this is another path-breaking technology, I think, which I would support a lot is microfluidics. Now, this came a couple of years back, and there has been a recent study, 2019, done by Yon Seok, and he demonstrated how he does an oocyte denudation in X-ray this year. So what he says is that there is an increase in the fertilization rate in cases of low sperm concentration or high DFI compared to conventional method of sperm preparation or sorting in ICSI or MC. Application of microfluidics in the IVF process is continuing to increase. Now, this has shown its help in maturation, insemination, oocyte manipulations, along with other processes. But the more use of microfluidics as per date in India has been for sperm selection. What is microfluidics? Is just nothing but a technology which is based on chips, which is fabricated with micro channels and chambers, which is made up of PDMS. And these channels and chambers have an inlet and outlet. So when you place them at an inlet, the low DFI sperm travels the entire channel, and they come at the outlet wherein they are picked up for the ICSI. In the denudation, they are just made to and fro in the channels, and the cumulus gets denuded from the oocyte. And definitely, when given a chance, it looks a more sophisticated and more better technique of denuding the oocytes, wherein the mechanical damage to oocyte while denuding is taken care of. So this is how it looks, the microfluidic channel, and there is an inlet, the outlet, so the dead sperms, the non-motile, the higher DFI all stay back, and whatever reaches at the outlet is the ones which are good. So we have been using microfluidics for the past 8 to 10 months, and we use it only for the high DFI, and we found pretty promising results, but it's too early to talk about the consensus on microfluidics, but it is one of the most important and most discussed topic in the conferences and initially this year. So now I think this is one of the most important and relieving factor technology for women who are career-oriented. Now, cryopreservation a decade back was not that encouraged because of the success rates, but thanks to the present media, the protocol, embryology skills today, and especially the media, I would say, and the protocols of freezing and thawing, which has got our post-thaw survival rate to almost 100. This, we encourage the women to go for social who have of husband during the ICSI protocol. Freezing has always been, but oocyte freezing now has seen a very good response over the last 1 year. So this is published in 2006, and this was a study which was done on 875 women by doll, and this showed, they studied with a live birth rate for women, and what they concluded was that in less than 37 years, you need 15 to 20 M2 oocytes for 70 to 80% chances of having one child. The blue line is one child. So if you see, the one child chances are almost 28 to 30%, 70 to 80%, you need 30 oocytes. But as the age increases, that is more than 38, you need 25 to 30 M2s to have just 65 to 70% chance of having one child. And if you can see here, it is drastically fallen down. So at this age, there is no point of oocyte freezing. So this is what we need to understand. And what is the most conclusion from this study was treatment outcomes using autologous oocyte vitrification and warming are as good as cycles using fresh. There is no statistical significant difference in live birth or ongoing pregnancy. 6.4% of live birth was given per vitrified oocyte. The clinical pregnancy rate per transfer were significantly higher in vitrified warm oocytes compared to fresh oocytes. Now, this could be influence of the a negative effect of the stimulation on the cumulative pregnancy rate. So this has to be one of the drawbacks was that the fresh cycles could have had a embryo transfer success rate a little lesser than the frozen cycles. But with this, there was another couple of studies which say that oocyte cryopreservation doesn't mean that it is an answer to everything. Oocyte cryopreservation at 8 of 5 would result in relatively 8% in probability of achieving a live birth and a relative decrease of 27% in cost per live birth. Then that oocyte cryopreservation remains a cost-effective strategy through 37 years of age. Now, this little benefit of oocyte cryopreservation at ages of 25 to 30 years with maximum benefits achieved with cryopreservation at 32 to 37. So when a young woman comes, we are not going to offer her oocyte cryopreservation. Maybe we wait till she enters the fourth decade, and then that's when we offer them the option of oocyte cryopreservation to have a pregnancy maybe later in the fourth decade. So this is very important for us to counsel the woman that who fits into a category of oocyte cryopreservation. Nothing works, everything and nothing works. Rejuvenation therapy, as you all know, works. We have stem cells, we have oogonial stem cells, we have induced pluripotent stem cells, and most easiest is the PRP. So what do these stem cells do? We just inject these stem cells into the ovary, and they generate exact copies and the ability to change into specialized cells, and then they can improve the stem cells of the oogonial hierarchy. And this is how they to a minimal certain extent. Now, where do these stem cells come? These can come from the tissues, the most commonly used, but these have not shown that good effect in fertility. So there are some embryonic, this is again still under research, that the inner cell mass can be an embryonic stem cell and can be used back for inducing rejuvenation in human ovaries. Induced pluripotent cells, yes, they could be taken from the cells and genetically programmed. Oogonial stem cells can be used in this way. These are the cells which are taken from the cortex of the ovary. They are again induced into pluripotent cells, and they are reinserted into the woman's ovarian cortex. And there have been a couple of studies on that, and they look like they may have a promising but the problem is the difficulty in retrieving those stem cells, culturing them, and putting them in. PRP is the most easiest one, and there's a lot of trials going on it, and there is a big Fecinoidis trial which has demonstrated that in an age of 45 years, they did it on the 8 perimenopausal women, and last year they had a biochemical pregnancy, unfortunately aborted at 5 weeks, but they have definitely confirmed restoration of menstrual cycle in 1 to 3 months of ovarian PRP treatment. Now, this was shown by a improvement in the AMH, resumption of menstrual cycles in the women, fall in the FSH. But how much it would be giving us a competent embryo is still to be studied. We have our own Dr. Manjula Anagani study, again talking about rejuvenation and restoration of menstrual cycles, fall in the FSH and increase in the AMH. Now, 3-parent IVF is, I think, again, a different arena to look at. And this has helped many people with mitochondrial disorders. Now, what is the concept of three-parent IVF is you take either a genetic material or a mitochondria from a donor or a recipient and put it in the opposite oocyte and make an embryo of that oocyte. Now, how does this work is, we all know that mitochondria is one of the most important organelle in the oocyte, and which is the basic energy reserves of the oocyte. And this mitochondrial dysfunction increases with age, and this disjunction can cause abnormalities in chromatid separation and resulting into finally an oocyte aneuploidy and a chromosomal abnormality. Now, this chaotic mosaicism in human pre-implantation embryos is correlated with low mitochondrial membrane potential, and this mechanism programs the fate of embryos, and hence the entire concept of mitochondrial transfers came into scenario. This was initially done in the US as a cytoplasmic transfer, when the cytoplasma of the donor with the mitochondria was put it into the recipient. But there came a problem of heteroplasmy, that is double mitochondria, and hence this got banned in the US. After that, a lot of research and studies have going on, and three-parent IVF is done in some of the countries where mitochondria from the oocyte is transferred into the woman recipient oocyte, or the maternal spindle has been transferred from the genetic mother to the oocyte, the donor oocyte, and the embryo made. So these are usually helpful in mitochondrial disorders, which could be genetic, familial, or age-related. So if this picture, if you see, that we could help the woman here with a pre-fertilization or an after-fertilization. So pre-fertilization, you can do a spindle transfer, that is from the recipient to the donor oocyte, or a mitochondrial transfer from the donor oocyte to the maternal oocyte, I mean the genetic mother. And this is then inseminated, and this embryo is a better competent one. Or post-fertilization, you can do a pronuclear transfer, though there are not much of research and studies on it, but there have been studies on spindle cell chromosome transfer or mitochondrial transfer, and they look promising for mitochondrial dysfunctions or advanced age. Now, another what future potential is germline engineering, that is the chromosome therapy, or there is no, with I think the present era of artificial intelligence, I don't see that there will be a long time when we see generation of new gametes in vitro. So with artificial intelligence and new gametes in vitro, I think we'll be seeing a different scenario of ART, maybe in a couple of decades or more. So I think in the last ART. Now, oocyte donation, there are, it could be offered to a woman who has very poor reserves, failed cycles, and there has been a certain cutoff kept in the woman to be offered with IVF-OD is majorly 55 is what the countries abroad look at, because after that the chance of having the age-related complications in pregnancy is high, and hence they limit option of ovum donation and more cycles of ovum donation. Adoption is there. Embryo donation, yes, the same applies for embryo donation, is 55 years of age and 6 cycles of embryo donation. Now, I think this is the last slide, and I think the most age of options available for the woman with the limited foods and less competent embryos. But what is the most important is counseling. The woman, that she needs to understand that natural fertility and assisted reproductive success are more important at the age of 20. So they need to understand that if they want to postpone their pregnancy, they need to go for maybe a cryopreservation at an earlier age, either oocyte or an embryo cryopreservation, or be prepared for the limited success rates of self gametes at an advanced maternal age and the option of third-party ART. So with this, the session is the main aim of in advanced is to get a good quality embryo. For that, we need to have a good quality oocyte, for which we need to prepare the woman better with individualized hyperstimulation, with protocol and gonadotropins to be given at the right dose and the right time, and or we counsel them to freeze the oocytes at an earlier age and then have the same success rate what they would have at an earlier age. Male factor definitely at an advanced age could be overcome by doing a DFI, ruling out high DFI, and in cases of high DFI, which is very much expected beyond the age of 45, with either TISA or microfluidics. And when you have a good embryo, you have to select the best embryo. So if you're planning for single embryo transfer in an advanced maternal age, you may consider PGTA, or maybe in a few days omics would come. And if nothing works, you have an option of rejuvenation, but the percentages of having a take home baby is very less with always a third party, but patients with the third party also. Thank you so much for your patient hearing, and I think that awareness about the impact of aging lifestyle represents the increased fertility. Thank you.
Ma'am, this is good evening. Good evening. This is Kiran here. I think thank you so much for a wonderfully put talk. You covered a lot of interesting aspects and interconnecting it with a lot of practical challenges and how to overcome the same. We can start the Q&A session, ma'am. There are a couple of questions, ma'am. Ma'am, you spoke about genetics in depth, ma'am. So the first question is, can you throw more light on the INHB, ma'am?
Yeah, inhibin actually is as promising in the US. Are you able to hear me, Kiran?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yes, inhibin B you're talking about is definitely as promising. See, what do AMH and inhibin are the only two factors which are secreted by the granulosa cell. So when the cell starts falling, the number of granulosa cells starts aging and the numbers come down. They produce a less amount of AMH and inhibin B. Now, if you see a decade back, AMH was in the same position what inhibin B is now. Inhibin B is done, assays are done in the US, but the problem with these markers are that you need very good assay systems to analyze. If you see a decade back, AMH had a very inconsistent report when it was done by CLIA, that is chemilucent techniques, so immunoassay techniques were done, and they were not that good, and sometimes the AMH would come 2, the next time you do it after 3 months, the AMH would come 5, which is very inconsistent and doesn't help us prognosticate the patient. But of late, from the last, say, more than 5 years, from the time Zen to ELISA has come, the reports have been consistent, and of late, from the last couple of years, Eclipse is there. Elixis is one of the new technology of assay of AMH, which gives very consistent reports, and it has been done by only 1 or 2 companies in India. So when we have such an assay, it can become one of the novel biomarkers for ovarian reserve testing. So at present, we only talk about AMH and AFC as one of the best promising reserve testing markers in advanced maternal age.
Thank you, ma'am. Wonderfully answered, ma'am. The next question is, you spoke about LH supplementation.
Yes.
So what are your thoughts on the protocols for LH supplementation, ma'am?
Yeah. There's a lot of studies and protocols of LH, and I think this year Eshrey was only talking on LH more, and I think artificial intelligence were the only 2 topics which was discussed in depth by Eshrey. And now in the last 2 years, LH, there is a very good study by Constantine which says that LH supplementation if it is a monotherapy with FSH, what you can do is you can go half and half with an LH from the day 2 of your cycle. LH is expensive in India, and there are a lot of studies which say that recombinant LH has given very good euploidy rate and good blastulation and good embryo clinical pregnancy rates. But I think the same would happen with the HMG along with the FSH from the beginning of the cycle. I think, as I discussed in the LH slide, This LH works wonderfully on the granulosa cells, and a very minimum dose of LH is very much required in the early it's basically and LH is the only has that. So it basically changes the scenario of the oocyte, makes it more and
Ma'am, your voice is breaking. Hello, ma'am.
Hello, can you hear me?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Hello. Ma'am, you're there?
Yeah, I'm there.
Yes, ma'am. Yes, ma'am. Now it's fine, ma'am. Ma'am, one more question is, ma'am, nowadays there is a lot of talk about the oxidative stress on the oocyte and it increasing accelerated aging. So there are a lot of specific antioxidants which are there, like melatonin, polyquinol, and what are your thoughts on them, ma'am?
Actually, I would say that everybody uses it because they don't do any harm. But till now, as I told you, the adjuvant therapies have no randomized controlled trials stating that they are of definite benefit in giving the better quality oocytes. Melatonin has a very good role in PCOS. The concept is different. But in advanced maternal age, which leads to DOR, the chances of the effect of these adjuvant therapy, if you ask my personal experience, yes, I use them and I have seen very good results. But if you see there are no randomized control trials and there is no consensus on the use of adjuvant therapy in AMA. What they talk is only about gonadotropins. Right. They talk a little study on the GX, that is growth hormone. You can use DHEAs, you can use antioxidants, but there is no strict or there is no proper protocol on the usage of these drugs.
Right, ma'am. Ma'am, you covered in your talk as well how important the male factor and the DFI also is in that. Yeah. So, what are your thoughts on some of these other adjuvants which are there, like vitamin D and
yes, definitely
reductase in reducing DFI, ma'am?
Yes. See, what happens is any gamete is a rejuvenating organ. It's a stem cell. So when a stem cell is growing, as you have a childhood, when you are, your stress in your younger age is definitely less. So the oxidative stress damage is increasing as your age increases. And supplementation of all good vitamins definitely restores the stress damage to the maximum. And we have seen that the supplementation of vitamin D, there is a lot of data on it. The supplementation of vitamin D in aged men and women trying to conceive has been shown to be effective and helpful. There has been a study of vitamin D3 in follicular fluid, I think by our own research center in Mumbai. And they have seen, and this was one of the discussion of topics in vitamin D in follicular fluid in ISAR. And they have shown that with the women who have less vitamin D3 in the follicular fluid of in the oocyte, during the oocyte stimulation, ovarian stimulation, has found a little lesser number of good blastocysts. So supplementation of vitamin D3 and calcium for some time before trying for ovum pickup or an ART cycle, I think would be suggested.
Thank you, ma'am. Thank you so much, ma'am. Ma'am, the next question is from Dr. Jayashree. What is your opinion about the testosterone gel and its usage, ma'am, right now?
There has been again a controversial data on use of testosterone gel. See, as the woman increases, the androgens do fall in intra-ovarian, in aging women do fall, and that's where LH works. So LH, the other use of LH is increasing the ovarian androgens, which are important for oogenesis. So where in the woman has a low testosterone, which you have documented, would be definitely helped by giving them an androgel or a testosterone patch. There are studies on testosterone patch in diminished ovarian reserve, and they have shown equivocal results. But yes, where you have a lower androgen level, testosterone level in the blood, maybe it would help. If you give growth hormone or if you give LH in your stimulation, this would be automatically taken care by increasing the intra-ovarian androgen levels.
Ma'am, I think there is one large-scale study which is going on, I guess, ma'am, on testosterone gel. Yes, ma'am. Yes, ma'am.
It was earlier. It was there was a lot of studies saying good effect of testosterone gel. But again, the Cochrane and the Ishray said started talking again equivocally about testosterone because LH came into vogue, and now again there is a lot of study. So DHA is again one of the very common supplement which is given, and if you ask me, I give it to every woman who is a low ovarian reserve, maybe a Posidin 2 or a Posidin 4 category, and I have seen personally very good results in women who has taken DHA for a minimum of 3 months before an ART cycle.
Thank you, ma'am. Doctors? So, ma'am, I think there are no further questions. Thank you so much, ma'am, on behalf of Shield Healthcare and the audience for giving a beautiful talk, as always. It is always a lot of learning, at least for me. You covered all the aspects, right from the clinical to the practical to the genetics of everything, ma'am. Thank you so much. And I would like to
thank you so much. And I thank Shield for a wonderful opportunity to discuss. And it was very good to have this session after Ashray, wherein a lot of discussion happened on this topic in the conference. And I thank all of you for your patient hearing.
Thank you, ma'am.
Thank you.